We are receiving a presentation today by, I guess, one of our own, our former health insurance commissioner and Rhode Islander, Christopher Kohler, on the national landscape of exchanges and some of the challenges, and hopefully he'll also present us with some opportunities as well. But before asking Chris to begin his presentation, I'd also like to turn it over to Chairman Miller for some comments.
Yes, I would like to welcome Chris Kohler also as a long-standing member of the Health Committee. He was invaluable as a commissioner and a resource, and now he's invaluable nationally. And that's why we were interested in having him lead this presentation. I also think it would be appropriate to have the senators introduce themselves, as we do have a joint committee present and we have one or two new senators. So I'm Senator Josh Miller from Cranston and Providence.
Senator Ed O'Neill, Lincoln, North Providence, North Smithfield.
Senator Juan Pachado, Providence, District 2.
Senator Christopher Adiano, District 11, Portsmouth, Tiverton, and Bristol.
Senator Elizabeth Crowley, Central Falls, Pawtucket, District 16.
Senator Cynthia Coyne, District 32, Barrington, Bristol, and East Providence.
Senator Sue Sosnowski from South Kingstown, and I'll also represent New Shoreham.
Senator Gail Golden, Providence.
Senator Adam Satchel, West Warwick.
Mr. Kohler, go ahead whenever you...
Thank you, Chairman Miller and Chairman DuPont and members of both committees. It's an honor and a privilege to be here and to work with you folks. I was talking to people beforehand. It's particularly a privilege when my budget is not on the line, so it's nice to... I hope that the information that we've got is of use to you as you work through these important policy questions. What I hope to do today is to talk about what the health insurance exchange functions are as defined by the federal government, to talk about the decision Rhode Island made, as Senators DuPont and Miller said, to talk about what we can learn from the exchanges, the state-based exchanges that have been set up in other states around these areas, draw some conclusions, and then, if not solutions, at least lay out some options for Rhode Island. I recognize that not all of you lay awake at night thinking about and reading on health insurance exchanges, so I would encourage you to stop at any time to ask questions as we go along. The point, as I understand it, is for people to get a fact base of what's going on. So if at any time terms are not clear, please feel free to interrupt and we'll just sort of work through them together. And by the way, the Milbank Memorial Fund where I work is based in New York City, although I'm still, Senator DuPont's my senator, thank you, sir. And we work with states across the country around various issues relating to health policy. So this is exactly our function, is to try to help states make good evidence-informed decisions. So we're pleased to be here. The Affordable Care Act sets forth 11 requirements for a health insurance exchange. They're grouped here sort of by their overall functions. And I'm not going to read through all 11, but just to note that the first two deal with this idea of how do you make a market? How do you try to make comparable health insurance, I'm going to call them plans. So plans are what you buy in the Affordable Care Act language. Issuers are what we think of as insurance companies. So how do you make apples to apples comparisons so that people can go and buy, make informed decisions about what to purchase, particularly when they've relied on their employers to do that, or they haven't had any choices at all. So the first two functions relate to how do you make a market, and usually that means working closely with your Department of Insurance, or in Rhode Island, the Office of the Health Insurance Function. The next six, deal with sort of the guts of setting up an enrollment and eligibility system. When you enroll, when you come to an exchange, not only do you have to choose plans, but the exchange has to figure out, are you eligible for Medicaid? Are you eligible for federal subsidies if you make more than what you qualify for Medicaid? Or are you purchasing with entirely your own money? That is intended to be, as designed, an online transaction. And when you hear about big system expenses, it is testing for, actually, I should reverse those. It should be eligibility first. So are you eligible? And then you enroll in a plan. And that is to be, that has to be done online because the consumer's expectation is that this determination be made real time. And so when you hire an information technology company, in the case of Rhode Island, they hired Deloitte, you are setting up a system that interacts with the Medicaid system, interacts with the federal government. It says has to determine, it can't take Chris Kohler's word for how much money Chris Kohler makes. It's got to go check with the IRS to see what were on the tax forms. It has to check Chris Kohler's dependents, make sure that he hasn't been arrested, make sure that he has a legal, a viable Social Security number. And so all of that is involved in the enrollment and eligibility system, and it's articulating those 6 functions there. But Chris Kohler probably is not going to push the button based on what he can find on a website. He's going to call up somebody to say, are you sure? I have some more questions. So the last 3 functions deal with how do you inform people about what their health insurance options and how do you help them enroll. They call it to provide a toll-free telephone hotline. It makes it sound like all you have to do is put a phone on a desk, but really you've got to set up people who are working through those same 6 functions that are involved in the eligibility and enrollment system. So you think of this is what every exchange has to do. If the state didn't take, I'm going to talk about this in a moment, if the state didn't take on this responsibility, the federal government had to set that up. And so much of the problems for the federal government when there was the rollout was really around those, the second set of 6, the eligibility enrollment system. It didn't work the way that it was supposed to. And then people would call, too many people called for consumer support, and actually those people had, the federal employees had the same problem interacting with the system that the folks who were trying to get information online. So that's really my first goal here, is to have people understand what it is that an exchange has to do. And these are the basic functions. You show up at the front door, you give your family information, your demographic information, your income information. The information system says you're eligible for Medicaid, you're eligible for an exchange, a federal subsidy, which is if you make more than Medicaid, or you're not eligible, but you still have to buy individual insurance, and so here are your choices for individual insurance. Does that help? Are there questions that come out of that? Yes, Senator.
Thank you. I have a question on number 4, grant unaffordable exemptions from the individual mandate. What is the unaffordable?
So you're testing the limits of my technical knowledge here, but there are in the Affordable Care Act, everyone has to buy health insurance unless you meet certain exceptions. Some of those are religious exceptions, but there also is if you do not have access to what is deemed affordable health insurance. So in the way the law was developed, I think the number is 9%. Yeah, that when you enter your income, you are supposed to be able to spend, you're expected to contribute 9% of that. If your 9% plus what the federal subsidies have available still don't allow you to purchase, then you're exempted. There aren't a whole lot, I don't believe there are a whole lot of what they call affordability exemptions. They're more the religious ones. Okay? This is a long slide. I guarantee we will not be this long after this. So why did Rhode Island go with a state-based exchange? And in the interest of disclosure, I was involved in developing this decision. It was obviously not the Health Insurance Commissioner was not the only person involved. There's a Health Reform Commission put forth by former Governor Chafee and chaired by then Lieutenant Governor Roberts. And collectively, a vision was put forth, sort of a high-level vision statement that says it's going to provide a marketplace for all Rhode Islanders to identify health insurance options and for those eligible to purchase coverage. That's been a pretty consistent vision from the start. What that looks like in Rhode Island is if you think of all the folks who buy health insurance, and we don't include Medicare, because Medicare is a separate federally run program. It's now I can say this. It's actually national health insurance for people over 65. But we put those out. The Rhode Island market, as people estimated around the time that the Affordable Care Act would start up, consisted of this is them projecting after Medicaid expansion. So these are post-Affordable Care Act. This isn't beforehand. This is a projection in 11 of what things would look like in 14. 200,000 Medicaid individuals, 69,000 individuals for whom their employer-based health insurance was too expensive or they had no access to it, and so they could buy from the exchange. 22,000 individuals who make more than 400% of poverty or their family income, and so they would be going through the exchange. 81,000 people in the small group market, and 510,000 who get their insurance through large employers, either a CVS or a state of Rhode Island that self-insures, or a mid-sized company that buys commercial insurance. So this is the entire insurance non-Medicare population in Rhode Island. And the exchange really targeted, as it was designed, or as intended in the Affordable Care Act, its sort of center focus were these individuals who are buying health insurance, whether they're getting a subsidy or not. But by law and intent, you had to be able to handle Medicaid folks. So if a Medicaid person comes through the exchange door, the exchange had to say, no, you don't qualify for the subsidy, you go for Medicaid. And for small employers, states, I can't remember, was it an option or was it the shop was required? So the small business health options, items on the, or products and plans on the exchange were to be made available to small businesses. Now we'll talk about what they call that the shop exchange. We'll talk about what that's been, what the experience with that has been. But it's important to, and the reason why I think the folks, myself included, who are working on this vision said that the exchange can really serve, and by law has to serve more than individuals. It has to be available to small business whether they want to buy or not, and it has to be a door through which you can enroll in Medicaid. And it may be a place that I want to go, even if I don't buy there, I want to check what the options are. I teach a class and I send my students to the exchange, even though they're not buying, just so they can learn the trade-offs. Okay, I can get a lower price, but I've got to get a narrower network or I've got to get a higher deductible. So, and the exchange, Rhode Island built that to allow for what they call anonymous browsing, so that people could go on there. But this is why, in designing the exchange and thinking about a state-based exchange, we identified these target populations. This is how we segmented them, if you will. Questions on this? Okay. So how have this decisions gone? This is a slide with too many colors. I think I want to focus up here. There are 16 states that are 15 along with Rhode Island that opted for a state-run marketplace that said we think that this decision around how to coordinate with our Medicaid program, how to coordinate with our small business program is important enough that we want to do this ourselves rather than give it to the feds. You can see that the states that did this are not of any one political stripe. We've got New Mexico and Nevada and Idaho opting for it. And in general, the decision, it sort of went from both sides. There were sort of three characteristics. Your market was so small that you had to make it work with your Medicaid. It wasn't like California where they got just tons of people, so you can serve them separately. You really didn't trust that the federal government was going to do it, so you wanted to do it yourself. Or you had done so much with Medicaid that you wanted to make sure, Medicaid managed care, you'd been a Medicaid innovator, that you wanted your exchange to work particularly closely with that. So either you had a small market where things had to fit, the pieces had to fit together well, you wanted to work with Medicaid, or you didn't trust that the federal government would make it work. So that's a pretty big generalization, but those are the characteristics of the states that went with a state-based marketplace, as opposed to giving it to the feds to set up. Okay. So if you look at the 16 state-based exchanges, I just sort of, in response to the request from the chairman, I tried to sort of think about what do they have in common. And we'll get into this a little bit later on. Everyone's grown their own. They have all done their own IT, and they all have done their own operations. 4 of them went with, to do that middle set of 6 things, ended up abandoning their state solution. Oregon had an internal failure, and they went back to the federal system. Maryland had an internal failure, and they adopted Connecticut's platform. They took Connecticut's platform and customized to what they did. And then New Mexico and Nevada came late to the party and said, we're just going to use the federal platform. So although people talk about sharing services, it's pretty hard to do. That's sort of the bottom line. That's been the experience so far. Now, frankly, some of that might have been because it was the federal money was made available, so there was an encouragement to do this all with grant money. But this is the path that the states chose. Questions on this? Okay. So what's been the experience? I did a slide this way to show 2 things. The blue is the eligible individuals, and the red is the penetration after the first year. So there was our first open enrollment period. From October until, I believe it was January, last year, people had they had to select their health insurance, and this is sort of the scorecard. So there was an open enrollment period when you had to come in, and there are reasons why there's only a certain time during the year when you have to buy health insurance. It's meant so that you don't wait until you're sick to buy it. It's called an open enrollment period. We had it in certain cases in Rhode Island as well. And the blue numbers show, obviously, I didn't even put California on here because it would completely blow up the scale. You couldn't even see Vermont and Rhode Island and D.C. So I took that out. But you can see that in absolute numbers, Rhode Island's are not very big, but as a percentage of the eligible, it is one of the highest that's there. So the red is a greater portion of the blue. The problem is that the blue is not very big. And that's sort of the punchline for why we're here talking about these sorts of things. And this is before the last open enrollment. So this is where we stood as of at the beginning of 14. On the SHOP, the Small Business Health Options Exchange, no one has had much success with that. So they've worked to make the options available to the small group market. The only state that has some relative success in getting into their small group market is Vermont, and that's because Vermont closed their outside market. In Vermont, if you're a small business, you have to go through the exchange to buy it. And they made that decision. Really, we're going to talk about that because of the size. It's kind of in for a penny, in for a pound. But in all these instances, Rhode Island actually has one of the better small group enrollments, and Rhode Island made small group outreach a significant part of its strategy. But the numbers after the first year that show that small group is pretty hard to penetrate for the SHOP. And that's because you're setting it up side by side, and people don't want to change if they don't have to. Questions on this? Okay, the third function is Medicaid, because that's the other thing exchange has got to do is reach out to Medicaid. So these are the numbers of new people enrolled through the exchange on Medicaid. The Rhode Island number is really quite remarkable because we had a fairly expansive Medicaid program before. So a place like Washington looks really good because their Medicaid was really low. And now when you put in these new Medicaid eligibility limits, there's a whole lot of people that come in. We weren't adding all that many new people, but of all the people that were eligible, we were able to reach out and find them. And on the outside, I would say that's because we established a very effective navigator program we were building on the back of Medicaid outreach. So that for its size, Rhode Island's performance here is quite good if you're interested in enrolling people, which is the goal of the Affordable Care Act. So what do I do? So this is a slide I think that we're going to spend a little bit of time on. A lot of numbers here, and I'll just sort of talk through it. This represents combining information from a number of different sources, and this helps put our operations for the Rhode Island Exchange in context. In the first column is what you would think of as kind of the core exchange market, the people who could buy through the exchange. And that is just combining the eligible small group and the individual market. That number, the number for Rhode Island might be a little bit different, but this is taking it from a consistent source. So this is using the Kaiser Family Foundation number, so at least we have the same source for all the different states. The next column is recapping what we talked about in terms of where the operations come from. I just highlighted the 4 states that I understand use Deloitte as the systems integrator, because they are the states, if we were looking at shared services, talking to other people that our current vendor works with is an option. The next column is information that I got from public sources. I just went on and Googled this, so I can't attest to I have documents behind all these except where I've noted it. But this is just what I could find for minutes and things like this. So I won't guarantee this to the accuracy to the 10th of a millionth of a dollar or something. But it is striking that regardless of the size, the numbers that are being quoted in the public documents where we could find them are relatively close, which leads you to think there's a significant economy of scale with the exchange. Whether you're setting up whether you have let's take one way, 109,000 potential market in the case of the District of Columbia, where their costs are 28, estimated costs are 28 million, or one that is 4 times that size, but only less than 50% more, which is the case with Washington. So when we say there are economies of scale, it means size matters. It's important to be big for something like this. The next column is how these state-based exchanges have decided to fund their operation. And there are really 3 options that they've identified. One is that you have an assessment based only on your members in exchange, and that's what is meant there when we say in exchange. The second is that you put an assessment over a broader set of enrollees. That's what's meant by broad-based. The people who did this work said in most cases, they don't know for sure, it looks like it's assessing everybody in the small group and the individual market. But in the case of the District of Columbia, they did the self-insured and the large group as well. And then the third way is to have a state appropriation to put out of your general revenue, which is what New York did. I'd also highlight Colorado that did a mixed. They collected a base across everybody, and then they charged extra to the folks in the exchange. The last column, and I would also note that those who experienced an IT problem and went back to the federal platform, the feds, frankly, haven't figured out how to charge them for that. That's an open question. The feds are still trying to negotiate with the states. In spite of that, Oregon's got a $31 million budget, even though they're not paying for IT. At least that's what their public document quoted. Now, maybe that's been changed since then. I haven't verified any of these numbers with the folks in Oregon. I just pulled it off. The final column is, given your funding mechanism, what do you need to collect to hit your number? It's really is a math piece, and you either do that as a percentage of premium or you do it as a charge. PMPM refers to per member per month, and that really is that's a number. That's I guess in the people on the finance committee, that would be a plug. Once you choose your financing mechanism and you have your number, your total number, you just got to figure out what the mill rate is to get to it. So, are there questions on this one?
I have one.
I thought there'd be questions on this one. So,
Chris, with regards to the second column, or the first column of data, the exchange market, small and individual.
Yes.
Those are numbers of individuals?
Those are individuals' independence. So that would be the individual market, the the families. When we talk about the individual market, it's not just the card holder; it's the dependents in that.
So if I compare back to, not sorry to interrupt you, but I compare back to page, well, it came from somewhere, the four
Right.
blocks.
Right.
I'm trying to figure out how do I get 114 for Rhode Island? Which blocks do I add?
You get
Is a sub piece of 1, 2, and 3?
81,000.
114,000, right?
Right. It's what your
91 for the second and the third one, right?
yeah, and so
We got 23 left somewhere.
we would get. I think the problem is that some of the subsidy individuals were not before this in the individual market. So people getting subsidies are actually employees of large. They're counted here as employees of large insurers. So this is the problem I said about counting. I just used the Kaiser source to get a sort of a consistent. What's the relative market?
Okay, to see, there's not a direct correlation between.
Two different sources, two different numbers.
Thank you.
Yeah.
Thank you, Mr. Chairman. I do have one other question, Chris. So I realize this annual budget's listed there for the various exchanges that we have here. Do you have some, not necessarily today, but maybe you can provide what the cost, I'll say the setup cost, this cost to create the system?
So,
because would be someone that, let's just pick one. In the case of Connecticut, they're looking at $35 million annually.
yeah, and I think these are run rates. This is 2015 after you've paid to set up the cost. So these would be
More specifically, the cost to set up the system was much higher than 35 million.
Yes,
Right.
yeah,
So
and that's the federal. That's money that was that was the purpose of the. And I didn't talk about this in my presentation, but those are funds that were made available to the ACA under the ACA to states that
appreciate that. I'm just wondering what they had to be in the billions somewhere.
Yeah, I don't.
If Rhode Island got 120, what was Rhode Island's number? 100 and something million, right?
Right around 100. Did we? What's that? Yeah, 140. Yeah.
So I would just, and I'm sure it's not exponential and not necessarily linear either based on the number of people because we're talking about technology and some of the other things. But if Rhode Island's one of the smaller ones, numbers of people, multiply the first 10 by,
right.
We're at $1 billion already.
Right.
Just in IT.
Right. I'm not sure.
Setup.
I focused less on the setup costs and more on the ongoing run because that was the number that we're going to have to deal with here.
If I could, just a follow-up, but if I look at Rhode Island, Connecticut, Washington, and Kentucky, they all had systems developed by Deloitte.
Mm-hmm.
One would expect Deloitte would have leveraged from somebody.
So I think that's a
setting up the system, right?
And I think I would say this as a close observer, but not a participant. The task for Deloitte to set up an enrollment and eligibility system for Rhode Island would be very different from the task to set it up for Kentucky. In some cases, because Kentucky just wants different. They want their website to look different, but mostly it's because Kentucky has different ways of doing eligibility and enrollment than Rhode Island does. So there's some parts that are common. That's a platform, but we could not to go to. And I make this point later on. To go to Washington, either we would have to change to Washington's enrollment and eligibility rules, or they would have to change to ours. Because there's a very different, the internal logic that Deloitte had to put together is very different for those two. So we would have to standardize not only the way the front part of the exchange works, but the way the back part does.
Okay, I don't want to monopolize the question. I'll ask the question after. Thank you. Thank you, Mr. Chairman.
Have any of these exchanges exchanged to enroll state or municipal employees?
Not that I know of, no. Anything else, or should we?
Senator Ardiano?
Thank you, Mr. Kohler, and thanks for the presentation. It was very complex, but I appreciate you breaking it down like this. As kind of what Senator Palmer was kind of getting at is you start looking at it and trying to draw correlations, the same vendors, different size states, what's the variable, how do you correlate what it's going to cost you versus your population and what you're doing? And I get that there is a little bit of apples and oranges here, so you got to be careful. But can you break down when we say annual budget, is that money that's purely going to the contractor for those middle 6 functions, or is that the contractor plus in-state employees, other subcontractors?
The whole thing.
So it's not that annual budget is actually multi-tiered, multi-level. There's other line items all over that.
The two big. I got a hold of Washington's board presentation. I didn't want to get too far into it because I think that's really the job of folks within the Rhode Island Health Benefits Exchange. But far and away, the big numbers were for system and for staffing for consumer support. You need a lot of help desk and things like that just to pick up the phones.
And lastly, if you could, IT for federal platform, do you know who, is there one vendor that's responsible for that we know of?
They went with, remember that was the failure with CGI, and then they kicked CGI out and they brought in kind of a super czar, and I'm not sure who the vendors were that they used for it.
Thank you, Mr. Chairman.
Any other questions?
So the key takeaways for this, for me, are how similar the numbers are regardless of size. They're not identical. $10 million here there is a big swing when you're trying to build a budget, but there are real economies of scale here, and there really are only a few ways that people have figured out how to fund it. You either charge for people in the exchange, for people outside, and for a small exchange, I'm not just going to say Rhode Island, it is very hard to fund the exchange just based on to allocate, that whatever the number is for Rhode Island, 15, 20 million, whatever, to allocate that just to the 28,000 people in the exchange.
So I guess, you mentioned earlier in your comments that, while there's always talk of, collaboration or consolidation or, hasn't happened yet in a practical sense. But, but to your point about economies of scale, and I realize that, there would have to probably be a significant number of modifications, but everyone's really, facing the same question, and that is, do we keep it? Can we afford to keep it? Or do we, dump it and go to the feds? But there's still a cost to go to the feds, right? To the ultimate premium payers. And so I've started to wonder and have had some just conversations with, colleagues about, we've heard real, rave reviews about how, our exchange and the infrastructure is really, far and away, a model. And so, I guess what I would be interested in knowing is whether or not there's an appetite, particularly from some of the smaller exchanges, to allow us to really leverage our infrastructure and almost serve, as a broker of sorts, and whether or not, those costs can be spread over a larger pool of policyholders.
So can I
don't know if that's part of your.
Yeah,
if it is, then
I get into to some of those. So if I could hold off on that, I talk some of those. So, as Senator DuPont was saying, the operational performance appears to be good, just in terms of percentage of market that we're reaching. Nobody's sharing services, and no state-based exchange has reverted to the feds, although people have looked to the IT for it. I have a separate slide about what it would mean to just shut down our state-based exchange. And size matters. There just really are economies of scale. To Senator DuPont's question, I think the small states, there is benefit from exchange among the smaller state-based exchanges because our problems, our challenges are not unique. D.C. has actually already settled it. I'll talk a little bit about what their solution is. And Vermont, New Mexico, and Hawaii are right in the middle of it right now. I was talking with people in Vermont and Hawaii about it just earlier this week. So if Rhode Island were to give up on its state-based exchange, the vision becomes different from that first slide. You're not talking about a place there when all Rhode Islanders go. as I understand the costs, it's a 3.5% surcharge on all exchange-based premiums. So it's a 3.5% add-on. It is only for the people who go through the exchange. That if you do the math, 22,000 times 3.5% of that 28,000 who are in the exchange, that premium, that's a considerably smaller number than the 15 or 20 million or whatever the number is for Rhode Island. I guess the number that was being talked about before was 20 to 25. So on an absolute sort of cost to the system, it's clear that that just throwing in the towel on the state-based exchange would be cheaper.
That 3.5% is greater for all.
Yes, that 3. Well,
greater than the other funding mechanisms that add a percentage to anybody who accesses health insurance.
Right. So would you rather? I mean, this becomes a math number. I talk about you could put 3.5% on only the people in a state-based exchange or smaller. It's a tax. Broaden the base, but you're funding something different when you broaden the base because you're funding it a state-based operation, whereas this 3.5% is going to the feds. So, but something to think about as you think about referring to the feds. It is an open question, what Senator DePalma was asking about what the accountability is for federal grant funds. I don't know. There's some discussion about that. That question's not been raised, but I can imagine that if you're asking about accountability for the federal funds, if we turned around and said, not done anymore, I don't know. I would imagine there'd be some speaks with some feds. The second is the call volume doesn't go away, so you would have to deal with people who are enrolling in the exchange through Medicaid, and you'd have to sort of extract out what you've built from a system standpoint, and I'm not qualified to talk about what that would look like in Rhode Island. The third is the most unknown, which is the pending Supreme Court decision on the legality of putting states running subsidies on the federal exchange. If the Supreme Court says that federal exchanges cannot administer these subsidies, there's going to be 6 months of all sorts of renegotiation. The feds might lower the bar of what constitutes a state-based exchange, so subsidies can go through there. I'm sure that the Republican majorities in the House and Senate would have something to say about that. So there's uncertainty because there's uncertainty about how the Supreme Court decision is going to come out, there's uncertainty about that's a risk in reverting back to the federal exchange. That decision's due at the end of June, most people think.
Senator Pearson has a question.
Yeah.
Thank you, Mr. Chairman. So on this slide, when you say costs, feds charge 3.5% of all exchange-based premiums. On your slide before, when you were talking about different states and how they decided to fund it, and you don't have to go back to it, I'll remember.
Okay.
In some of them, you had said the funding mechanism was, quote, in exchange. And when I look at the ones that were in exchange, there were some states, Minnesota, you put 3.5%, others 2%, Maryland and Hawaii. So other states it's the same way, right? So the feds are saying 3.5% in their exchange. Other states are saying 2% or 3.5%. So other states are funding the exchange cheaper than the feds are funding it just by charging within the exchange. So if we give it back to the feds, we're not saving our taxpayers anything.
It's the question that I think the point that Senator Miller made. It is it would be to have a 3.5% charge that's levied on the premiums in the exchange, so those people are paying that extra amount, or it's a smaller amount that's charged over everybody. And I think I was talking to a guy from Idaho, and he was very fixated on that 3.5% number. He said, because Idaho's got big numbers. Idaho's got a lot of uninsured, so a lot of people coming through the exchange. So he just said, look, if we can do this, he said, we did this for 2.5, I think that's the Idaho number, because we knew we had a point to spare, and that was all he cared about was that federal number. It's different, I think, for if you're only charging people in the exchange, put it this way, if you only want to charge people in the exchange, reverting to the feds is a bargain, because you would have to charge something way more than 3.5% to generate that 20 million or whatever it's going to take to run a Rhode Island. I haven't looked at the numbers. I don't know what it is. 10, 20, whatever. 3.5% of the exchange premium doesn't generate a whole lot of money.
But for the other states, so I'm just trying to understand what you put on here. So for Hawaii and Mass, for instance, you put in exchange in at 2 and 2.5. So
Right.
they're funding it at 2 and 2.5.
They're funding at 2 and 2.5. Hawaii's problem is that's not well, both of them have. Actually, they both have relatively small volumes inside their exchange. So I don't think.
How are they balancing it?
Yeah, Hawaii's not going to be able to make that number work because they've got nothing in there. So
I'm just looking at it. I'm saying, okay, if it's that simple, then. Okay. So there's some deficit that they're going to have to overcome.
Hawaii's they've got a real problem.
So they have a funding mechanism, but they haven't actually fully funded it.
Correct.
Okay, gotcha.
Exactly.
Thank you.
Based on that discussion, there is a larger discussion about when you charge for just those who enroll in an exchange, are you misunderstanding the concept of insurance in general? That if you enroll more people in insurance, savings are beyond those you're insuring. The savings are to not only people, the more people you insure, the less insurance is supposed to cost. Just charge within the exchange. Are you misunderstanding the complete concept that you are potentially creating savings for those who enroll elsewhere, and the savings that are recognized to providers because they are now providing to those less people who are uninsured?
So I think you're asking who benefits from the exchange. And I've got a slide that talks about that, but you can make an argument that says that more than the people who roll in the exchange benefit from it. Employers benefit because they're part-time and they don't have to, there's less economic pressure on them to provide benefits to their part-time employees, because if they're under 30 hours, they're classified as part-time and going to an exchange. There's some hard to value individual benefit from knowing what your options are when you go and look at it. That you are getting a hold of your own choices and deciding what those trade-offs are, and those might be a benefit later on. I will say the District of Columbia made that decision that everybody benefits from this, so we're going to charge everybody. They spread their base over not just small group and individual large group, but it looks like they're self-insured as well, and or at least they're dental and some other stuff. So they establish a very broad base for it.
So Milbank or others qualifying that with any data on the impact to outside the exchange?
No, I mean it's a percentage cost. It's a tax question or assessment question. Do you want to charge a lot to a few people, or
has anybody tracked, or is it not enough time yet to track the appearance of the climate that is created from an increased insured climate?
No, I mean, because you get into sort of what are the social benefits of having everybody covered. Is there there's an argument to be made that you encourage entrepreneurialism when you have when you make it easier for startups to get health insurance.
As an example, our hospital association was tracking the impact of Medicaid enrollment.
Right.
And what revenue that brought to hospitals.
We haven't done anything with that yet. So to close, if we hand all operations back to the feds, we're changing our policy. It's complex. It does save money. The total costs coming out of Rhode Island are less than they would be because there's no way in the immediate future that 3.5% of the exchange volume is going to generate $10 or $20 million, whatever the cost of an exchange is. But there are risks around negotiating with the feds about it and the outcome of the Supreme Court case. If you decide to do it local, next three strategies are not mutually exclusive. We're starting to understand what it takes to run a state-based exchange. Places like Washington are reducing to a core. There are certain functions that are more important than others. I'm not familiar with the Rhode Island budget, so I'm not presenting any kind of analysis of what's there. Number of people asked about shared services. They can achieve cost reductions, to Senator DuPont's question, if you can standardize enrollment and eligibility policies with your partners. If you can get rules that are pretty similar, if you can come to a vendor and say our rules are pretty similar, you can get some savings. If you're doing a custom job, it's going to cost more to set up and more to maintain. In the same way, if you can get some economies around staff savings, a common help desk or something like that. And again, I can't quantify those. It'd be a question directed to the administration. The other options are, and Senator Miller was talking about this, expand your denominator, the number of people in the exchange. The choice of channels is not costless. If you want to have choice, if you want people to be able to choose from inside the individual the exchange and outside, there are costs associated with that. It's the same with small group. It's worth noting that there are 11,000 people who are enrolled in Blue Cross who did not go through the exchange. They enrolled directly with Blue Cross. And there are 86,000 that are enrolled in outside carriers. Both the District of Columbia and Vermont, small exchanges, elected to run their entire individual, small states, elected to run their entire individual and small group markets through the exchange. Obviously, there are significant risks associated with that. They were particularly felt in Vermont, where the exchange did not perform the way that they thought. D.C. did the reverse. D.C. shut down its market or moved it all through the exchange in the second year, once they kind of proved it in the first year. And then the third part of that strategy is to expand the assessment base. And this is the argument that Senator Miller made, that the people who benefit from the exchange are not just those who enroll directly in it. In the example, we talked about part-time employees who come through the exchange to get insurance from someplace else. Again, the only state that's done this, as near as we can tell, is D.C. It's spread their base very broad. And it's worth noting that we have other assessments that are market-wide for things that we determine to be public goods. We do it for immunizations. We're doing it in a way in Rhode Island for the health insurance, for the health information exchange, current care. So those are really, I think it's important to be in dialogue with the other small states that are working through this. In effect, the District of Columbia already made their decision. It's very much up in the air in Vermont. New Mexico seems to be puzzling with this, and Hawaii is, as Senator Pearson noted, it's got real problems. They don't. It's not clear what their strategy is. I don't know if you want to organize a fact-finding trip to Hawaii on the coldest day of the year, but this is a small state problem. It's a small market problem. And the reason that we'll close with sort of the slide we had before. You can ask, is the vision still valid, or make a statement that the vision is valid. All these people are going to be looking for insurance. This is a problem of a small insurance market. I dealt with it myself. We ran a regulated utility for individual insurance with Blue Cross and Blue Shield. And looking at my colleagues at the PUC right now, it's tough to run a regulated utility. But if you want to have choice, you got to pay for it. And it becomes compounded in a small state like Rhode Island. So that's it. Questions? Or
Senator DePalma, then Senator Satchel, then Senator Golden.
Chris, thank you for doing this. It's much appreciated. And during our work session, that time in February, we'll talk after. We can schedule that trip to Hawaii.
Right.
Well, and do the insurance research.
Right.
We'll get a fact-finding trip on exchanges.
Then federal funds look pretty good for those sorts of trips, right?
They take a couple months, though.
Right. I think we'll maybe get a federal grant for help us with that. But no, thank you. A couple of questions. I don't want to maybe ask a few more later, but talking about the 3.5% that the feds would charge, and whether the federal case happens or doesn't happen, or what other states have done already. Rhode Island right now charges 2% insurance premium tax on all insurance, so I understand it. So one of the things we can look at is, right now, we have 114. If you can go back to the chart, how many folks are currently enrolled?
In the Rhode Island,
Is it about half?
About 28,000.
So 28,000. So the 28,000 times those, multiply that by, or take the total insurance premium they're paying. 2% of that's already coming into the state in the general fund.
Yes.
So obviously it's in the general fund, it's being used. As more folks sign up, that goes to the general fund. So that 2% potentially becomes, it's in the general fund. It's not there now. It's a policy decision with regards to that 2% that's already paid, that's already being paid into the system, that could pay for the exchange to some degree.
Right. You could take, so if I understand your argument right, there's 12,000 more people insured now than there were prior to just through the individual market. Put
Correct.
Medicaid aside. We got a lot more people in Medicaid. We could take those 12,000 people have generated an extra 2%.
Right. So whatever that X is,
right,
that they pay totally or annually, on average, do we know what the average premium that is paid by?
No, there are other.
Can you pick a number?
2 years out of date. There are other people here who know that number.
But if you were to pick a number, what would you pick a number?
I'm not going to know. Help me pick a number. Brenda, what's the individual market premium? So 300. 300 for an individual. That's
per month.
Family.
That's per month.
Yeah.
Okay, so let's say $4,000.
Yeah.
Right. 2% of that times 20,000 people. Right. It's a lot of money.
Hmm.
So in looking at it, and obviously there's been a lot of discussion about this, turning it to the feds is a cost. So there becomes I'll say a floor or a ceiling, depends on how you look at it, that said there's a cost to moving it to the feds that the state would have to incur. That has to be incurred anyway. So that becomes maybe the floor or the ceiling upon which you potentially say that's what the state should provide, and everything else after that the exchange has to figure out. But more back to so I'll have to look at what those numbers are. We'll do that on our trip out west. But in looking at the exchange itself, so I've used the exchange. I was one of those anonymous users, and I also had a constituent that used it. And the challenge with the exchange became they needed insurance that day. It was the 25th of the month. The exchange said, yep, you got insurance a month later on the 1st. So 35 days later, the individual was going to get insurance, and they needed it that day. The exchange said, sorry, we can't help you. You have to call before the 23rd. So the individual then went to I won't say the insurance provider, one of the insurance providers, same plans are listed there, exact same names, same dollar amounts, no subsidy. This person wasn't going to get a subsidy for it, and got the insurance that day. So there's a challenge and some feedback was, we're only providing what the insurance companies provide. Well, that wasn't the case in that regard there, but in going through the anonymous approach, I'm not certain I fully buy the complexity of the differences in the system, because not a lot of information you enter in the very beginning. Mm-hmm. Maybe later on there might be a little bit more, but it's the basic information: who you are, what your name is, what your income, how many dependents you have.
Can I take a stab at part of the problem with your example is that subsidy part, obligation of the exchange.
Agree.
More often than not, there is subsidy, and that 30-day period qualify the subsidy.
I agree, but the piece about there's a whole bunch of folks that aren't getting the subsidy, but are going through to get insurance. With regards to the complexity, have you looked at many different, including Rhode Island and many other states, and talk about the complexity of the data that has to enter? Because it wasn't that much.
And so your point, your
point with regards to,
is it really that complex?
Right. From the technology side of things, it's a couple of decision branches that have to be made.
So you're talking about there are two parts to that. The exchange needs that information for eligibility. Then it actually has to enroll. It has to.
Yes.
It has to. Yep. Send the information over. It has to coordinate a flow of funds coming from multiple sources, and I think that's part of the complexity when they're billing. So they got to get federal funds. They got to get the individual funds. They got to get. They got to communicate the information to the health plan. So
but every state would have to get individual funds, federal funds, state funds, or whatever. So that that path, once you got beyond the unique piece, you went into this, I'll say, process.
And I think
So to try and talk about...
It's a good question. I think it's better directed to the people who run the exchange.
Okay.
I guess.
Thank you. Thank you, Mr. Chairman.
Thank you, Senator Satchel, and then Senator.
Thank you, Mr. Chair, and thank you for the presentation, Mr. Kohler. You had mentioned shared services on slide 14, it looks like. Given the fact that Connecticut, Vermont, Rhode Island, we're all small markets. We're in a very small geographic area. Connecticut and Rhode Island both use Deloitte for IT. Has there been any discussion about a sort of regional market where states get together and have one exchange? Do you think that that would work?
When I was health insurance commissioner, we were asked to look at regional insurance markets, which is different from the exchange. And the conclusion was that it would be hard to establish a regional insurance market because everyone liked their own rules around health insurance. And so it would require statutory harmonization among the 6 states, and that was going to be very hard to do. I think at the operational level, sort of what, there's a policy conversation around can we make our rules the same, and then there's an operational level around can we really share operations. The policy conversation is really between you as the policymakers and your colleagues in Rhode Island Vermont or Connecticut. The challenge with collaboration is people say collaboration's fine as long as you collaborate with me, and so that was always our problem with Massachusetts. And so I think you have to show benefit why it's in the other state's interest to collaborate with you around policy. Operations, I think it's reasonable to ask people who run the Rhode Island Exchange how much could you get in common with Deloitte, with Connecticut? And that's sort of what Senator DePalma was getting at, and I don't know the answer to that. I do know that Connecticut's got different Medicaid eligibility than we do. They got different, some different exchange rules. What it would take to make those common, I don't know.
Thank you.
Senator Golden.
Thank you. So I have 2 questions. My first question is, you mentioned that there's risks associated with increasing the denominator as Vermont had done. And then in terms of mandating that small business and that there not be an external individual market other than in the health insurance exchange. Can you talk about what those risks are? Do you mean just operationally because it all flooded in at once, or was there some other,
I think
given that we're going into year 3, would there be the same risk of us doing that now?
There are 2 risks. The first is operational, and that's what tripped up Vermont. It's just, as you call it, the flood of people coming in. I think that risk is much diminished now. It's not eliminated, but it's diminished. And the second risk is the risk of asking people to change. It's mostly a political risk, and there are some communications risks. So when you tell people they have to buy health insurance it's one thing to say to people who haven't had health insurance, this is the way to buy health insurance. That's what we were doing with people in the exchange. But when you tell people they have to buy health insurance a different way, that's change, and that brings with it political risk. I think the Rhode Island Exchange has spent a lot of time working with brokers around the small group market because small group strategy has been part of it for a while. So there are a number. I've talked to brokers and talked to small businesses who've gone through the exchange and found it a change, but one that was worth doing. So, but whenever you ask people to change, there's resistance.
And do you mean individual purchasers, or do you mean the health insurance market itself? So the health insurers.
Mostly the purchasers. It's the small businesses, the employees who work for those small businesses, and the brokers who advise those small businesses. You're asking all of them to do something different.
Okay. And my second question is about Medicaid. which on slide 13, in talking about if Rhode Island were to return the exchange to the feds, talking about extracting the Medicaid operation. So since we've actually seen a very healthy, robust enrollment in Medicaid, which I assume is attributed partially because it's much easier to actually get it with the customer support that was lacking prior to that. So you're talking about the call volume of people enrolled in Medicaid through exchanges front door. So you mean that in order for us to maintain the quality of the enrollment process that we currently have for Medicaid eligible Rhode Islanders, we would still have to incur costs associated with that?
Exactly.
Which we were not fully investing in prior.
Right.
Thank you.
Senator Sheehan.
Thank you, Mr. Chairman. Thank you, Chris. It's good to have you back here. Always impressed with your depth of knowledge and your sincerity. My question is, it looks as though right now, as I understand it, that the feds charge, 3.5% through their exchange, and that's essentially supporting their programs nationally, whichever states participate in the federal exchanges.
I don't think anyone has a clear idea as to whether that is sufficient revenue that they're generating.
Whether or not they're writing a blank check in addition to that, whatever it may be. Now, it seems that also for Rhode Island, and you've done some analysis here in Rhode Island, that whatever we would have to charge to sustain the program, it may be run efficiently, may be managed well, but the numbers don't justify, it won't pay for or cover continuing that program. Is that a fair statement?
Yeah, let me restate it, because if you were to assess only the people in the exchange,
the program,
to cover the costs of running a Rhode Island exchange, it would be considerably more than 3.5%.
Okay.
I don't know what that number is, but it would be more than 3.5%.
Okay. When you say considerably, you don't know what it is. I will not hold you to this number, but are we talking about 10%, 20%, 5%?
Earlier this week, Senator, I tried to get a hold of the Rhode Island premium volume. I just didn't get to it, so I can't. I wouldn't even hazard a guess, because that's a findable number pretty easily, and I wouldn't serve you well by taking a pot shot at it.
So basically, our choices are raising the fees significantly for people within the program, within the exchange, or finding some other mechanism, tax-free otherwise, to raise the money to supplement the program to afford it going forward. Is that fair?
Yeah, but the amount you have to raise depends on some of these operational questions that Senator Satchel was asking earlier. You're raising money to match a number, and the number that's going to take is something that's up for
up to debate.
It's up for debate.
Right. Okay. All right. Thank you. Thank you, Mr. Chair.
I'm sorry. To Senator Golden's question, if you moved all your volume through the individual and small group market, if you shut down the outside the exchange markets, you could probably, I don't know what you'd have to model what that is, but it's possible that then you're talking 100 to 125,000, and there are states that are with 100 to 125,000 in their exchange that are doing it for less than 3.5%. So I just want to qualify, you're laying out options. Yeah. Another one is to only charge people in the exchange, but put more people in the exchange.
Right, and they would come from outside of the exchange and what private program, private insurance policy programs?
They would say, they'd still be private. You're just saying the market for small group and individual is, and that's what D.C. did, and that's what Vermont's done.
So in essence, is that basically saying we will tax them to support the system, broadly speaking?
We're saying when you work for a small employer or work for yourself, here's how you get health insurance. You don't have a large employer to make the market, so we're making the market for you, and we're giving you subsidies if you can't afford it, and that's not a costless proposition.
All right, thank you. Thank you, Mr. Chairman.
Senator Pearson.
Thank you, Mr. Chairman. So I know that in the beginning of when we started talking about health source and building our own exchange, one of the things that we talked a little bit about, I'm not sure if you're the right person to ask the question, was integrating the exchange to also be able to assist with other social services. So checking for SNAP eligibility benefits or TANF or other social services. Is that something we ended up doing?
Other people in the room can answer that question better than me. I believe it was not on the first phase, but it's part of the plan. I wouldn't say we're using the exchange enrollment process as a chance to do that. That's not an exchange function. This money is not paying for that.
So the
process.
IT infrastructure doesn't alleviate. So I'm thinking, so we may be saying when you enroll, we'll all say, oh, by the way, you're also eligible for X, Y, and Z. That's sort of a way to help people understand the full spectrum of benefits are available for. Where I was thinking was wondering if we were using it at all for any of the administration function or any of the signing them up for the eligibility benefits for those other things.
There are other people who can answer that question better than me. We can have them answer that question right now, or you can wait. It's going to...
Yep. We'll come back to it.
Okay.
Thank you, Mr. Chairman.
Somebody can correct me if I'm wrong, but it's set up to allow for those kind of enrollments. State wishes, is that correct?
Yeah. You have to rely on multiple experts for this. Part of it, knowing when you're out of your league.
Somebody has an answer.
Hi, my name is Linda Katz. I'm the policy director at the Economic Progress Institute, so I don't work for the state. But just what Rhode Island's plan was to replace the outdated Inroad system that processes eligibility now, and use the new technology that has been built to process eligibility for health insurance, which is both the Medicaid piece and the coverage through the exchange, and to both move. There's a lot of other routes to Medicaid coverage. So if somebody's disabled, for example, they don't get coverage through the exchange right now. They go to DHS and get coverage there. So one thing is to move all of the Medicaid coverage populations into one system, one integrated system, and then the vision is also to move the other work support programs into that same integrated system. So building on efficiencies and also consumer ease of accessing services, the plan is, and my understanding is that by the end of July, all of the other Medicaid pieces will be in. And for somebody who's a working low-income person, for example, when they go to apply for health insurance coverage, they will also be able to just put their information in one database or one eligibility system that will also determine whether they're eligible for child care assistance and for SNAP benefits. And other federal sources are funding the build for that system. But it's basically from the consumer perspective, sort of trying to build one-stop shopping for work support services for low and modest income people, and also to make sure that people who may switch from one category of Medicaid to another, or where there are family members who are qualified for Medicaid based on different categories, all can apply for coverage in one system. So it's a very consumer-oriented, streamlined government services approach.
The back end of that is going to be, as we look at that, I think we got to consider what are the ways in which we make the systems and the processes align. So that way, and one way we could fund partially part of this exchange is from existing funds from other areas of state government spent administering those other programs, right? And so we got to start thinking about how do we become strategic in the investments we're making.
Right. Well, and I think when Chris, the issue of moving the exchange, the health insurance part of the exchange to the feds, the state still will need to determine Medicaid eligibility, so there still will be a cost for doing that. And Rhode Island is went down the path of saying, from the consumer perspective, we want to have one-stop shopping for health insurance coverage. And just give you an example, the Medicaid limit for a single adult is like $16,100. So you have people who apply for coverage. The system determines whether they're Medicaid eligible because their income is below that, and if not, says, oh, you can buy coverage through the exchange and get tax credits to help you pay for it. If, let's say, somebody went into Medicaid and during the year they got an increase in their income because they got workforce development training and got a better job. They're no longer eligible for Medicaid. They don't have to go somewhere else. They have one account, and they can just flip into buying coverage through the exchange.
On the other side, as a cost savings to the state and the federal government, because so much of Medicaid is and the other programs are federally subsidized, is that you have an annual scrutiny on whether somebody still qualifies for those benefits.
Right. There's one system, and there's post-eligibility checks of people's income that go on now. So I do think as the examination is made of if we did take the part of just the exchange eligibility and take that out and give it to the feds, what the impact would be on Rhode Island's decision not only to have integrated access to health insurance coverage, but also integrated access to all of Medicaid and to the other programs. And there's a cost there if we do that.
Thank you. There also is savings that comes from qualifying several programs under one system.
Yeah,
and savings in that you monitor whether you still qualify every year. And there's also one thing that we keep discussing that maybe needs a further discussion is also the impact of subsidy and the assurance that you're preserving subsidy in a state-run program. There is an economic impact to the state of hundreds of millions of dollars of money that goes into the economy as a result of subsidy. And so when we talk about the insurance concept in general, we should also talk about the economic impact on the state of Rhode Island for putting money in people's pockets versus subsidy.
And so I would, yes, and I would sort of take a step back and say all these are issues for small state-based exchanges. We're talking, Rhode Island's not alone. It's an issue that Vermont, D.C., New Mexico face, and I think these discussions are going on in parallel in each of them. I think because of some of what Senator Miller is talking about and Linda Katz, it's not a surgical extraction to give it to the feds. It will be hard or would be hard to disentangle those pieces, and I think that's why the small states are looking at what is the right size for their state-based exchange. How do we sustain it? What's the right size? Can operations be shared, and how should it be financed?
Senator DePalma.
Thank you, Mr. Chairman. Chris, looking at the numbers, can you go back to the table, if you don't mind? Just to make some, then based on the calculations I've done, they'll be correct. So where it says Rhode Island and it says the exchange market is 114,000 individuals, people that are in our market. If I understand it today, we have about 28,000 of those 114,000 in the system. Based on some of the calculations I did, the 2% right now, based on an average of $3,600 times 28,000 people, that's about $100 million. 114 average, or round it, is 4 times that. That's $400 million that would come into the system. 2% of that is about $8 million. 3.5% of that's about, let's say, $15 million. Is that the correct? Those calculations, those percentages in 114 and 28 are correct, right?
That logic sounds right. You've got crack analytic staff for your committees, so they can run it through.
Well, I just did it on my phone here, but the
it's a crack phone.
I did get an error on one of the numbers I calculated because it was way too large. But in looking at that, I think I just want to step back. I think it comes down to I would never disagree. The system's very effective. The response time when I called and the person I know had called was almost immediate. If every other system in the state was like that, we'd be. Yeah, you're right. They're going to handle some other areas as well, but obviously there's a bunch of people to take those calls, so there's funds there to do that. What it comes down to is the decision about efficiency, right? How do we ensure the system or the systems we have in place with ours or shared or whatever the issues are, the issues associated with working with other states, is how do we become as efficient as we can so every penny that goes into it is minimal, so that at the end of the day, insurance is important. It helps everybody. It helps. I'm sure it brings down the cost for everybody. Obviously, insurance companies benefit a fair amount from $100 million to $400 million. That's $100 million that wasn't in the system before. That's a lot of money. A lot of money into the economy, so it's jobs as well. If we got all 114, which I think that's utopia or altruistic, we're probably never going to get all 100% of those. That's $400 million into the system. So at a 2%, that $8 million is what that 2% would generate of the insurance premium tax today. That's going to, right now, $2 million of that goes into the general fund because it just does. But the other $6 million can't be accounted for yet because it doesn't exist. So that might be a way we look at how do we become efficient and do it. But the real challenge is, well, without a lot of facts and data, I know we'll try to surmise this is better or that's better or whatever, but there's probably a lot more facts and data required from the exchange in Rhode Island to really understand and appreciate, to make sure our numbers are correct, and have that, I'll say, thoughtful, fact-based, data-driven discussion with other states to say, how can we do this more efficiently? Unless we can answer the question today that we're doing it as efficiently as we can. I'm not saying anybody would say that. Maybe they will. But I think, is that what you're seeing from what you're looking across the, so long discussion to a quick answer of what you're seeing across the country?
I think that this has been a very high-level overview. I think learning from the other states that are in a similar situation. I wouldn't go to California and say, how do you do this? It's just, I mean, they got umpteen counties that are bigger than we are. But I would.
But you do recommend Hawaii. You do recommend Hawaii, right?
And
it is almost 6:30, so we should figure out a way to conclude this. But there are a few things that, at least I think the Health Committee would be interested in looking at going forward as statistics, is to quantify the subsidy and how much is the state willing to pay for the economic impact of subsidy. How many contracts does the state or municipalities participate in, and how much would that increase the base of who would participate in exchange if they were included? Those would be statistics I would be interested in. I'd also be interested in whether Millbank, because I know they do these kind of things, would they be interested in potentially at some time in the future convening smaller states that have similar issues? I mean, maybe it could be very interesting to have Connecticut and Maryland as part of that, because they have looked at and tried to execute a combined service, and that experience would be interesting also. So those are a few things I think post this informational hearing that I would be interested in having us look at.
Senator, I'm impressed that even when I don't work for you, you can find work for me to do. That's.
I've traveled to some of your
never in Hawaii,
and not Hawaii, but I know it's something that you're interested in being part of.
No, this is sort of convening. Exactly. We'd have to think about. We would need the leadership of the legislators, because all this is happening in a compressed time frame. So we would need your input about how to have this happen within the time frame of the legislative decision making.
Thank you. I mean, I would just have to agree with Senator Miller. I think, this was very helpful in terms of providing that 35,000-foot view. But I'm certainly very interested in the data, and I think a lot of it will have to be provided by Health Source, and I obviously understand that there's some changes taking place there. But I'm intrigued by the human behavior aspect of it. I mean, we're talking about the numbers that we're looking at obviously are static, but I'd be interested to see in terms of what the spike is a week before the deadline, in terms of folks finally saying, oh, I've got to enroll. And so those numbers are obviously, I would suspect, going to continue to be a moving target. The other interesting piece, and I'll close here, is that I'd be interested in some of the more detailed data regarding I know in the presentation it had the 11,000 currently directly enrolled with Blue Cross. What percentage of those folks would or would not be eligible, for subsidy? And for those that are eligible for subsidy, if they go through the exchange, why aren't they? I mean, it's a significant number. So I think what I'd like to propose is that maybe, wait a few weeks or a month or so to try to get some of that data and have a follow-up to this so we can start to analyze some of those details and get a better idea as to what some of the other in-house options and considerations may be, which will be driven by, subscriber activity. So,
and I think part of your challenge, if I may, is that fourth column from the left, the annual. What's the right number there? When you, that's the challenge of a public function, is where the market isn't determining what the right number to run an exchange. We figured out the right number to run an airport. When we were thinking about the exchange, we were trying to think about what are public utilities that, where there isn't competition, you just got to figure out what the right number is. And so figuring out what the right number is, and that's a number that's driven largely by IT and a few big vendors. Are there ways to crack down on it?
Great. Thank you all very much for your participation. I'd entertain a motion to adjourn, made by Senator Miller, second by Senator Palmer. All in favor? Aye. Opposed? Thank you very much, and good evening.